I'd like to thank you for inviting me to speak today. My name is Daniel Talmor. I'm the chair of anesthesia, critical care, and pain medicine at Beth Isreal Deaconess Medical Center in Boston. And I'm going to speak to you today about the use of transpulmonary pressure at the bedside. This is a topic which is receiving increasing attention and has, in the recent years, also been built into ventilators, making it more accessible than ever. So I'll start by disclosing my sources of funding. They're all here. Importantly, I have intellectual conflict, which is I have opinions and I'm about to state them. So we'll start from the beginning. Clinical trials of PEEP in ARDS. This is a list of the major clinical trials, and it shows the results of each of them. Amato in 1998 demonstrated a benefit of low tidal volume strategy combined with PEEP. He set PEEP by the lower inflection point of the PV curve. The ARES trials seem to confirm this strategy, but unfortunately, both of these trials were confounded by the use of high versus low tidal volume ventilation in the two separate arms. So they're not really useful today. The alveoli trial stopped early for futility. The LOVES trial showed no benefit. The EXPRESS trial set PEEP based on the airway plateau pressure. The results were mixed, but it didn't really show benefit to higher levels of PEEP. The ART trial from Brazil, published a few years ago, actually showed harm from higher levels of PEEP, but those high levels of PEEP were combined with very aggressive recruitment maneuvers, which may have actually caused the harm in the intervention arm. And most recently, the RELIEF trial out of the Netherlands compared PEEP of 5 or less versus a PEEP of 8, and it was a non-inferiority trial. So it showed that those two arms were equivalent, but actually likely both arms were harmed by the low levels of PEEP delivered in each arm. So having reviewed all of these trials, we can see that there's really a very mixed message around the use of higher and lower levels of PEEP. And I'd like to try to explain why we see that mixed message. So if we take patients and everybody's getting a low tidal volume ventilation, 6 mLs per kilo, some of them receive a lower level of PEEP and they'll have a driving pressure of whatever. Some are randomized to receive a higher level of PEEP, and those patients will have the same driving pressure. The overall effect of the high PEEP intervention will be null. So there will be no effect because we're not really recruiting the lung. We're merely driving the PEEP and plateau pressures higher. So hidden within that group are two separate groups. Those are patients who are non-recruitable. So by increasing the PEEP, we push the plateau pressure up, we increase the driving pressure, and those patients actually are harmed by the high PEEP. On the other hand, there is going to be a group of recruitable patients. And in those patients, increasing PEEP recruits the lung, the plateau pressure stays the same or goes up slightly, but the overall effect is a decrease in driving pressure. And those patients will be benefited from high levels of PEEP. So the question at the bedside, the crux of the entire PEEP issue, is how to identify those group of recruitable patients here in green, how to find those patients in whom an increased PEEP will cause more benefit than injury, may drive down the driving pressure. And instead of doing large RCTs where we take everybody and treat them the same, we should be focusing on those recruitable patients. And how do we identify them at the bedside? So when we set the PEEP, we generally set it based on the airway pressure. And you can see in this cartoon, airway pressure is measured at the ventilator. But the pressure that actually interests us is not the airway pressure, because the pressure applied at the airway does two things. It opens up the lung, and which we call the plateau pressure. So the plateau pressure is the pressure actually distending the lung. but the airway pressure also pushes the chest wall out and will be highly affected by the weight of the chest wall. So the pressure we're interested in is the transpulmonary pressure, not the airway pressure, the transpulmonary pressure. And that's the pressure actually distending the lungs during ventilation. And it may be very different from the airway pressure. So the transpulmonary pressure is the airway pressure minus the pressure required to push the chest wall out. Now, in some patients, in fact, in many patients, the pleural pressure may be high. Why would it be high? Because they've been massively fluid resuscitated, so the chest wall is very heavy. The pleural pressure may be high because the patient is very obese. The pleural pressure may be high because the abdominal contents, when the patient lies supine, are pushing up into the chest. So many patients in the ICU have a high pleural pressure. And if we don't take that into account, if we don't think in terms of the transpulmonary pressure, we may be ventilating our patients incorrectly. And this is a graph from a study we published years ago, looking at the estimated transpulmonary pressure, the PL, comparing it to the airway pressure. And you can see that at any given transpulmonary pressure, the airway pressure varies widely. And why does it vary? Because of that component of the pleural pressure. And unless we take that into account, we really don't know what we're doing with our ventilator. Now, how might we take it into account? So this is a picture of a device called an esophageal balloon. We place the esophageal balloon through the nose or through the mouth, down the esophagus into a retrocardiac position. Now, this is a standalone balloon. It's more or less the width and consistency of a piece of cooked spaghetti. It's non-injurious. You will see now these balloons integrated into nasogastric tubes, which make them actually easier to place. And over here on the right, you see Mr. Ray Ritz, who was our head of respiratory therapy, placing an esophageal balloon. And this is a meeting of respiratory therapists. And I would tell you that this is a procedure that should be in the hands of respiratory therapists. They're able to place these balloons, make the measurements, and adjust the ventilator based on the findings. Now, what do you get when you place the balloon? So you get tracings. You get tracings of the esophageal pressure. And you can see the esophageal pressure there in the middle tracing. On top of that is the airway pressure. And this is coming from a computer which integrates the two. So it subtracts the esophageal from the airway pressure and gives you on the bottom tracing the transpulmonary pressure, the pressure actually distending the lung, the pressure that we really should be interested in when we're ventilating our patient. Now, this is on an older standalone laptop. It's from a research rig. Nowadays, these are integrated into most modern ventilators, making it extremely simple to get to begin to use esophageal pressure at the bedside. You just connect the balloon to your ventilator. The software is built in, and it will help you in your clinical decision-making at the bedside. Now, do the esophageal pressure measurements actually reflect the pleural pressure? And this is from a very old study by Paolo Pelosi, published in the Blue Journal. They placed esophageal balloons in dogs who had ARDS, and they compared it to the actual measured pleural pressure. So this is an experiment that you can't really do in humans because you can't place pressure measuring wafers into the lungs of humans, but you can in dogs. And what they found is that the esophageal pressure measurements actually very well reflected the measurements of the mid-lung pleura. And you can see this graph showing the correlation. It's an excellent correlation, meaning that we can use the esophageal pressure measurements as a surrogate for the pleural pressure in the mid-lung area. And it's not surprising that it would reflect the mid-lung area. But these are CAT scans of the dogs involved in the study. You can see that I've passed a line through the esophagus of those dogs. It's not entirely posterior structure, and that it would reflect the mid-lung area is not surprising. So the esophageal pressure measurements mean something, and they are a plausible, a good surrogate for pleural pressure that can be used to calculate the transpulmonary pressure, which is what we're interested in. The esophageal pressure is interesting, but we're really interested in calculating the transpulmonary pressure. This is another study since published in the Blue Journal by Lorenzo Berra and Marcelo Amato. They took EIT and compared those measurements to the transpulmonary pressure. Now, what you can see, this is collapse on EIT, and you can see at very high PEEP levels, there's no collapse. But when you get to lower PEEP levels, you begin to see collapse of the lung. Now, interestingly, the point at which you see collapse of the lung on EIT is the point at which the transpulmonary pressure becomes negative. So what does that mean? It's the point where the ventilation we're delivering from our ventilator can no longer hold up the chest wall. The pressure of the chest wall begins to collapse the lung. So we want to try to keep our esophageal pressures, our transpulmonary pressures above zero, preventing this collapse, which they observed on electrical impedance tomography. So this is further evidence that we can use esophageal pressures to calculate transpulmonary pressure, and it has actual meaning in the patient's physiology. Now, before I continue, I just want to say a few more words about the use of esophageal pressure measurements. Everything I'm going to talk about today has to do with setting the ventilator based on esophageal pressure. But there are other uses for esophageal pressures. And just to summarize them briefly, I can calculate the driving pressure of the lung instead of the driving pressure of the respiratory system, which is what we usually do. I can use esophageal pressure measurements to optimize my recruitment maneuver. If you think about it, it makes more sense to recruit to the transpulmonary pressure and not to the airway pressure, because that's what the lung actually sees. And I can use esophageal pressure measurements to detect dysynchrony, and a lot of work you'll see in the literature on using esophageal pressure measurements and inflections in the esophageal pressure to help detect dysynchrony and measure the work of breathing. All of these are great uses of esophageal pressure, but I'm going to concentrate on setting the ventilator. Now, years ago, Dr. Gattinoni, one of the pioneers of our field, published this paper in which he hypothesized that ARDS really has a couple of different subvariants. One is pulmonary ARDS, where the injury is mostly in the lung and not the chest wall. And one is extrapulmonary pressure, ARDS, where the lung is injured, but much of the injury occurs because of increases in chest wall elastance or the weight of the chest wall pushing down on the lung. So he divided this into pulmonary and extrapulmonary ARDS. Our use of esophageal balloons allows us to be more scientific in finding these patients whose ARDS may be affected by the chest wall and may benefit from different types of ventilation. And I'm going to give you before I move to the clinical use, I'm going to give you the last piece of evidence that these measurements mean something. So this is an anesthetized obese patient in our operating room. And you can see we're measuring the airway pressure. We are measuring the esophageal pressure. We're measuring the lung volume, and we're measuring the flow into the lung. And I'm going to zoom in on that middle area, which looks interesting. So what we've done here is we've disconnected the patient from the ventilator. We've allowed the lungs to completely collapse. The patient has no lung volume. And then here, we reconnect the patient to the ventilator. Now you can see that even when the patient is disconnected, there is an esophageal pressure because there's a chest wall pushing down. You also see the cardiac oscillations. That's the heart beating against the esophageal balloon. So we've reconnected the patient to the ventilator, and here we begin to deliver pressure with our ventilator. Okay, right there. Now, please notice that in all of this red area, while the ventilator pressure goes up, there's no volume actually delivered to the patient. There's no flow into the patient's lungs. It's only when the airway pressure is greater than the esophageal pressure. So airway minus esophageal pressure is your transpulmonary pressure. So it's only when the transpulmonary pressure turns positive are we overcoming the weight of the chest wall and beginning to see air actually enter the lungs. And only in this green period, after the airway pressure is above the esophageal pressure, transpulmonary pressure is positive, do we begin to see inflation of the lungs. And you can imagine on the flip side, as we deflate the lungs, once we pass the esophageal, once we pass the airway pressure becomes lower than the esophageal pressure, we'll no longer see flow out of the lungs. So this is a demonstration, an N of 1 patient showing that these esophageal pressure measurements mean something. And I'm going to walk you through a case on how we use it at the bedside. So this is a chest x-ray. It's a patient with post-traumatic ARDS, fractured pelvis, loss of circulation to the legs, anasarca, tense abdominal wall. And we found this patient in the morning on a controlled mechanical ventilation, tidal volume of 535 cc's. Don't ask me why it was exactly that. An FiO2 of 1 and a PEEP of 13. So we dropped an esophageal balloon into the patient and we made measurements. And this is what we found. So airway pressures were high. The PEEP was 13, the plateau was 40. So normally you would worry about a plateau pressure of 40. The esophageal pressure, however, was very high as well. So when we looked at the transpulmonary pressure, it was actually only 6 at end inspiration, and it was -8 at end expiration. Now, -8 is not a correct number. There's not, there's no vacuum in nature. So what that actually means, it merely symbolizes that the weight of the chest wall was higher. So the esophageal pressure was higher than the airway pressure, and this patient was collapsing their lungs at end expiration. So a negative transpulmonary pressure at end expiration, bad. What did we do with this patient? We increased the PEEP, okay? So we increased from 13 to 26. Pretty high PEEP, right? I'm sure most of you would not apply 26 of PEEP without a strong rationale. That increased the plateau pressure from 40 to 46. Now, how many people here like a plateau pressure of 46? Not many, right? But we had evidence on which to base this. And here were the measurements afterwards. So the airway pressure is now going from 26 to 46. Esophageal pressure relatively unchanged, but the transpulmonary pressure is now going from 4 at end expiration to 12. So we've brought the transpulmonary pressure into positive territory. The patient is no longer collapsing at end expiration. And when we measured the driving pressure, it actually decreased. So even though the plateau pressure was 46, the driving pressure has now decreased from 27 to 20. So if you think back to that initial figure I showed you, this was a recruitable patient with whom we were able to recruit using the esophageal pressure measurements. And for what it's worth, this was the chest x-ray afterwards, which seemed to show better aeration. So this is a clinical case of use of esophageal pressure at the bedside. Note, it allowed us, it showed us that this patient was very PEEP responsive. It gave us a way of reducing driving pressure by recruiting the lung appropriately to this specific patient. So this is personalized ventilation at the bedside. Now, we've published 2 trials on esophageal pressure use at the bedside. And this was the first one. This is already about 12 or 14 years ago. It showed a benefit to ventilation guided by esophageal pressures versus empiric low PEEP. And you can see the survival curve there. The survival curve is not positive. The P is 0.13, but it definitely shows that this intervention caused no harm. When we adjusted for Apache 2, it was actually a significant benefit. So this paper comparing esophageal pressure measurements to empiric low PEEP, what showed benefit to use of transpulmonary pressure at the bedside. So we followed that up with this second paper. This paper was different. So here we compared esophageal pressure measurements to a high PEEP strategy, because the question I was most asked after the first paper was, well, just turn up the PEEP, okay? But the point is, we don't just turn up the PEEP. When we use esophageal pressure, we titrate the PEEP to the patient. So this paper was designed to show that titrating the PEEP to the patient might be better than empiric high PEEP. Unfortunately, the bottom line picture of this study was that it made no difference, that using a esophageal catheter and measuring transpulmonary pressure was equal to an empiric high PEEP strategy. But if you dig a little deeper into this paper, there is a message that we can take back to the bedside. So as I said, in the initial EPVent trial, we used relatively low levels of PEEP. In the subsequent trial, we used high levels of PEEP. So PEEP at a FiO2 of 0.5, patients were getting 18 to 20 of PEEP. At an FiO2 of 1, they were getting 22 to 24 centimeters of water PEEP. So this is really high PEEP. And in fact, if you look at the levels of PEEP delivered to the patients in the EPVent 2 trial, you can see most patients in the control arm were receiving approximately 20 of PEEP. This is very different from what we know goes on in the community. So this is data from the LungSafe trial. LungSafe, to remind everybody, is a survey of ventilation and treatment practices for patients with ARDS. Here, even at a FiO2 of 0.1, most people in the community were giving a PEEP of 10. Almost everybody was within a range of 10 to 13 or 14, and very rarely were patients getting more than that. So EPVent 2 control did not really reflect what goes on in the community. Why did we decide to use high levels of PEEP? Well, when we designed the trial, it seemed like high levels of PEEP were indicated in patients with ARDS. That hasn't really played out. So it was an unfortunate trial design decision that was made back in 2012. And if I could walk it back, I would. But we still have a responsibility to try to find a message here. So the set PEEP levels weren't substantially different between patients in the empiric high PEEP arm and the esophageal pressure arm. You can see they're pretty much the same throughout the study. In fact, the transpulmonary pressures were almost the same throughout the study. So these high levels of PEEP really mimicked what we would do with esophageal guided PEEP. The question is, would you be willing to deliver these levels of PEEP at the bedside in your ICU if you didn't have the support of some evidence that they would benefit that specific patient? And here's where I think that clinicians really need to understand that we showed no difference from high levels of PEEP, but if you're not willing to use high levels of PEEP empirically, you should rely on the guidance of your transpulmonary pressure estimations with esophageal pressure catheters. And when we took the patients in the trial, mixed up the control and intervention arms, and then divided them based on whether their transpulmonary pressure was plus minus 2 centimeters of water, so around zero, or their transpulmonary pressure was higher or lower than that, we found that those who were close to a transpulmonary pressure of zero, so plus minus 2, actually had improved survival, and this was statistically significant. So if we relook at the EPVEN2 patients, we can see that the transpulmonary pressure measurements actually made a difference. And if you have the capability, you should be dropping the balloons, titrating PEEP to within plus minus 2 centimeters of water, and that will show a survival benefit for your patients. We looked again in a different way, measuring heterogeneity of treatment effect. So this is a big deal now in ARDS. You know, when we have severely ill patients, they can die from ARDS, or they can die from a million other reasons, most importantly from the sepsis or the trauma or the pneumonia that brought them in the first place. So we need to try to isolate the effect of our intervention on ARDS rather than the overall mortality, which may be much more affected by the underlying disease. So that's the principle of heterogeneity of treatment. If the patient has a 99% mortality because they have an Apache 2 score of 40, then whatever I do with the ventilator won't make a difference, okay? So this is a new concept in when we're looking at our trials in ARDS. We need to be thinking about what can we actually impact with our intervention. And what we found was that patients who had a high risk of dying, so a high Apache score, did not benefit from use of esophageal balloons because their mortality was actually driven by the underlying disease. The patients who had a lower Apache score, they were the ones who could benefit. So what do I suggest? Okay. Oh, and here that is in, sorry, this is a little out of order. Here that is in a graph, okay? So if you had a lower Apache score, your the esophageal guided PEEP group did better. The empirical high PEEP did worse. If you had a higher Apache score, the esophageal guided PEEP did worse, the empirical PEEP did better. So these are patients in whom the underlying mortality isn't driven by the ARDS, it's driven by whatever else brought them to the ICU. So what's my underlying message here? First of all, let's all agree that mechanical ventilation should be personalized. I should not be giving 5 of PEEP to everyone or 8 of PEEP to everyone. I should be thinking about what this individual patient needs and trying to use my ventilator to meet that patient's individual personalized needs. Secondly, esophageal pressure has multiple uses in mechanical ventilation. I can detect asynchrony. I can look at the work of breathing of the patient. I can look at I can recruit the patient based on their transpulmonary pressure. I can look at the driving pressure of the lung, but I can also set the mechanical ventilator. And that is what we've concentrated on here. Setting the mechanical ventilator so that the PEEP gives you a transpulmonary pressure of around 0, so plus minus 2. You don't have to hit 0 exactly, that's pretty hard. But plus minus 2 improves outcome. And it's going to improve outcome in patients whose survival really depends on treating their ARDS. and not patients who are going to die anyway because they have, a car ran over their head. So I suggest dropping these patients in anybody who has any type of ARDS, looking at the findings, thinking about the patient, and then, if appropriate in that patient, titrating the PEEP to a transpulmonary pressure of 0. And this is really part of an entire strategy of enriching patient care, okay? So this is be there, physiological phenotyping, looking at the patient's physiology. But we're going to be able to incorporate that soon with imaging, okay? Ultrasound machines are now all over the place. We can ultrasound the lungs. EIT really has reached the tipping point where it's taking off and is accessible at the bedside. So using ultrasound and EIT to provide imaging, previously you had to drag the patient down to the CAT scanner, which is nearly impossible in my hospital anyway. But we now have bedside imaging to integrate with the physiology. And we have new approaches to looking at patients based on their biomarkers and their inflammatory profile to identify people who are hyperinflammatory versus hypoinflammatory. We take all of this together and we get an integrated approach to decision-making that I believe will be more important in this decade in treating our patients with ARDS. So I'd like to thank you all for listening to me. I'd like to thank my study group who are, make really the base for everything I do. And I would like to thank all of you for listening to me. And I hope that you will take the message from this talk, go to the bedside, use your modern ventilator to measure transpulmonary pressure and improve your patient's outcomes. Thank you all and have a great day.